My name is Dr.O'Dea. I'm a breast medical oncologist at the University of Kansas Cancer Center. So both of these assays, Oncotype DX and MammaPrint, are genomic assays designed to help us understand more about the biology of the individual breast cancer so that we are able to individualize treatment for that individual patient rather than looking at a statistic, for example, of thousands of women with hormone-positive breast cancer. How can we pull out the individual features using tests that can look at the DNA of the individual cancer? It is sort of a way to allow us to have personalized medicine and to make sure that the recommendations that we're giving about whether or not a person, for example, will benefit from chemotherapy after their surgery or even sometimes before their surgery for women that have hormone-positive breast cancer, if that will be needed or if that will be helpful in improving their outcome or their prognosis from breast cancer. Both of these assays have been studied extensively with thousands and thousands of patients. For the Oncotype assay, lots of trials looking at patients that have both lymph node negative and lymph node positive disease. For the MammaPrint assay, the largest trial, of course, the MIND-ACT trial, which included patients both with limited lymph node positive disease and lymph node negative disease. So again, both of these assays, very, very valid and lots of data, lots of patient experience behind them. Typically, I would not say that one is better than the other. I find that sometimes it is easier to extrapolate, or sometimes we get a slightly clearer answer for patients to understand and interpret from the Oncotype assay. Based on the recent responder data that we have, which was a large clinical trial that looked at patients with hormone-positive breast cancer and patients that had 1 or 2 or 3 lymph nodes involved. They were randomized again to receive chemotherapy or not, and looking at the group of patients that received chemotherapy based on that Oncotype score, so that we were able to tell from that trial that women that were postmenopausal had to have a score greater than 25 on the Oncotype assay in order to really derive substantial benefit from adjuvant chemotherapy. Conversely, if you had patients that were premenopausal at the time of their diagnosis, they actually still benefited from adjuvant chemotherapy, even if they had a lower Oncotype score. So understanding the individual factors for each patient, so whether or not their age of diagnosis, whether they were premenopausal or postmenopausal, and then looking at that data, it really helps us very clearly kind of extrapolate that to each individual patient. So that tends to be, for my lymph node positive patients, that tends to be the assay that I will order just based on that large prospective trial, the responder trial, of course, presented by Kevin Kalinske recently. So I find that information has been really helpful at helping us counsel each individual patient. And so that tends to be the assay that we use more often.